and I would have expected a slightly better audience, but maybe this will improve by tomorrow. So, folks in Karachi, let us support this meeting as much as we can. Okay, so I'll talk about curbing the HCV epidemic in Pakistan. As has been mentioned, we are the #1 country in the world, unfortunately, for hepatitis C. 10 million Pakistanis are viremic, which means that they have active infection currently as we speak, and this is the highest burden from anywhere else in the world. Just to dramatize this a little bit, every 20 minutes, a Pakistani dies of hepatitis C related complications, whether it is liver cirrhosis or liver cancer, and we know that we are undergoing an epidemic of liver cancer mainly because of hepatitis C, for other reasons also. The other sad part is that if you look at the bottom part of this slide, and these are now recent data, relatively recent data from Punjab and Sindh, and the infection seems to be increasing and not decreasing. And here we are talking about elimination of hepatitis C, which seems really anomalous, but that is what the situation is. So Punjab has gone from 2007 to in the 2008 survey to 8.9 in 2018. In Sindh, 5% to 6.1%. So this is not a good statistic. And why is this happening? Basically because we have a huge iatrogenic spread of this infection within our people. Now, how did we get here? This is some work that one of our PhD students did in a lab in Japan with Masashi Mizukami. And it's difficult to explain the whole scenario of what this is, but this is a system of a molecular clock, which tells you what strain was introduced within a population at a particular time, and therefore you can sort of plot out the frequency of the disease itself. So, based on that molecular clock analysis, this is the maximum likelihood estimates of effective number of infections. And as you can see, this really takes off around the 1950s and continues to climb in a really exponential manner. What was happening here? In the 1950s, the first 5-year health plan, action plan was defined, and that included a number of vaccinations, including many smaller and other health interventions. And then we had the large smallpox vaccination campaign, which was 1964 to 1982. And this apparently played a big part in the spread of this infection. And then, since then, how the infection has propagated is blood and injection safety. If you look at the bottom part of the slide, the Emro region where we are located has the highest number of unsafe injection use in the world. And we are a significant contributor to this. Until we take all these preventative measures, we are the dream of elimination. The elimination of hepatitis C is going to be a dream and not really a reality. So I think we need to be sure that we are looking after these features as well. Look at the red row, and if we do nothing, we will get up to 100, and we've already gotten up to 171 million people who need to be screened, who are eligible to be screened, because our population is increasing and because our prevalence is increasing. So this is going to be a huge burden. Now, having been involved with the hepatitis response in Pakistan since the very start, you can see here that there has been a number of stops and starts. And this is really what happens in most of our public health programs. There is a start, and then there is an equally efficient stop, because nothing happens for many, many years. So we started in 2005, there was a first program, then there was another Prime Minister's program in 2006, then there was devolution of health, and then they became the provincial programs, and so on. Until, and that process has continued. It has not yet solidified completely. Having said that, we have made reasonable progress towards hepatitis C elimination. And why is that? I think that is primarily because of the fact that there has been a lot of diagnosis and treatment in the private sector as well as the public sector. Some of the provinces have done well. For example, Punjab has done well, Sindh has done reasonably well, so that we have been able to, as an estimate, we have been able to diagnose so far 30% of our population, of our infected population. And that's the first step. You need to know who is infected, how many people are infected, so that you can treat them effectively and so on. And there has been about 16% cumulative treatment for these patients that have been diagnosed. So this is not too bad, considering that there has not been a concerted national effort at elimination so far. And why has this happened? This has happened primarily for one reason, I would suggest, primarily for one reason alone, and that is that we have got the cheapest combination of drugs, generic drugs and good generic drugs in the country from anywhere in the world. We can treat a patient of hepatitis C for 12 weeks, which means 3 months, under $60 a month, which is really fantastic, because we know that these medications will cure 95 to 96% of patients if the patients are compliant. And that is the reason why I think we've done quite a bit. Besides that, there have been other programs like micro-eliminations that we've been engaged in, which means you define an area and you screen everybody, and whoever is positive, you start to treat them and so on. So we've worked for quite some time in a district called Malir, which is just on the outskirts of Karachi. We've been doing this since 2019. In this area, we've screened about more than 100,000 people, and we've diagnosed and then treated close to 5,000 people. So these kind of efforts have been going on, but again, these are not concentrated, concerted efforts that are needed. Now, the latest part is the yet another National Hepatitis C Elimination Program announced on the 29th of July 2024. We are almost about a year out of that program, and this is from the government that is in office at the moment. And there's the Minister for Planning and Development, who was, and some of the chief ministers of the provinces who were part of this program or part of this launch. And let's see now what happens. We have an elimination strategy. We need strong leadership and governance, which should be under the Prime Minister. We have we want social mobilization and sensitization of the population. That is a critical step, because otherwise nobody will come in for screening for hepatitis C. We need to screen the entire population of the country, which is more than 12 years of age. What is the cutoff? Why is the cutoff? Because less than 12 years, we don't see a lot of prevalence of hepatitis C in these kids. So more than 12 years of age, treat those who are eligible, and there should be surveillance and data monitoring, and then prevention of new infections, which I've mentioned already is critically important. So what is happening with the current program, which is supposed to run from 2024 to 2030. As we know, the WHO mandated time is 2030 for elimination of hepatitis C. So there is ownership of the Prime Minister. He seems to be involved directly. Let's see how much that makes a difference. The PC1 has been approved. It is worth 68.25 billion rupees and is also approved by other entities. The money is not yet dispersed, but still it is fully approved and ready to be implemented. The distribution is that the Federation will provide half of this amount, 34 billion or so, to the implementing partners, and I'll tell you how this will be utilized. The second phase, this is the first phase, the 34.75 billion. The second phase, we hope, will be given by national and international donor funding, and let's see under this current environment, how we do there. Federation will bear the cost of supplies of screening. So all the rapid tests will be given by the Federation. The RNA, the PCR tests, 30% of them by the Federation, and medications 50% by the Federation, while the rest is given by the provinces themselves. So 68.25 billion over 3 years, and the project cost is shared equally between the Federation and the provinces. So here are the targets: total population 253 million approximately, eligible population more than 12 years 165 million. This is 3 times the population of Egypt, because people give a lot of examples of Egypt where they eliminated. That population was about half of, in fact, it was only 50 million that they had to screen. We have to screen 165 million people, so a tall order. 50% of these 165, which means 82 million, should ideally or would ideally be addressed in the first phase. As I've said, federal government will provide all the screening, 30% PCRs, 1.7 million PCRs by the federal government, and 3.8 million treatments by the federal government. There is what has been done so far. So there's a national task force that has been established. This is under the leadership of the Prime Ministers directly. The members are federal ministers, chief ministers, and secretaries. This is already in place. This is not yet, maybe it's met once, but not entirely. The technical advisory group is us. We've been there since many, many years, as I've already said, and we're ready to help whenever we are called to help. A project management unit is under creation in the federal ministry, and that will execute the project in coordination with all the provinces. An IT cell under the project management unit is an extremely important step. The media cell, the procurement cell, and the data analysis and monitoring and evaluation and training cells. So this governance model has been developed and is being developed. We have mapped out the whole of Pakistan in terms of health facilities, and this is a map of the elaborate work that has been done, and so that we know where all the assets are, the private sector, the public sector including, so this has been completely mapped out. The electronic medical records are a very important part. The electronic data management is a very important part. This is in coordination with NADRA, and we just heard a few days ago that your NICs are going to be your medical record numbers also. This will greatly help in getting the totals together, in getting everything correct at the same time, and avoiding duplication. There are call centers. There's a portal, online portal where people can register. There is an active move towards a public-private partnership. We have developed an alliance which is called HEAL, Hepatitis Elimination Alliance, which is primarily consistent of a number of private partners, private entities, foundations, hospitals, etc., which will work in tandem with the government hospitals to try and get this work done. So while we were waiting, we thought we would do a small pilot project just as a demonstration project, and this was done in the Gilgit-Baltistan area, which is, of course, is a federally administered area, and it has a smaller population, so we thought that we should be able to do this quickly and try and get the the Gilgit-Baltistan province at least perhaps free of hepatitis C even before the national program is started. So the total population is small, it is 1.78, eligible population 1.16 million, and the HCV prevalence was a little bit unknown. This was just a guesstimate that this was 7.9%, but I think this was too high. The key strengths of this area were that there's a very high literacy rate, a strong population as I've suggested, there was strong local support, ample health facilities. The challenges, of course, are there's a difficult terrain, extreme weather conditions, and so on. But anyway, with the help of the Yaghan Development Network, this work was started some time ago, and we selected 2 union councils, one in Shigar, one in Daimar, and the total population of these 2 councils was about 14,000 or so. And these were then there was a training program. The government buy-in was there. All the local people were very happy to be part of the program. And this program then started in the beginning of February, it took about 10, 12 days to complete the screening. 14,000 people screened in about 10 or 12 days with a rapid test. The prevalence that came out was quite low. It was 0.24%. So in a way that is good, because this is not a very high prevalence area. Those who were viremic were then started on treatment, and this process is still ongoing, and we are awaiting final results. The electronic medical records, so this was all done electronically. This worked very well, and the data has been gathered in a very nice fashion. There were some challenges that were seen, and these are important to take care of, because this is what will influence the national program as well. So waste management was an issue. Training was an issue. Data management gaps were there, because in some places the internet would not work, and people would not be able to load these things onto the main EMR system. Infection control measures were lacking in these teams that were going out into the communities. So that need to be strengthened. There's counseling was needed, and of course there was a lot of transportation costs that were required. But anyway, so the idea was just to show you that this is a process. This is now well underway. We hope that within the next 2 or 3 months there will be a massive implementation of this program, which has already been thoroughly vetted and is now funded as well. So let's hope that this will move, and so that we need to remove that label that Pakistan has the highest hepatitis C infected population in the world. We are adding at least 100,000 new cases every year. This has to stop, and we know how to stop this, because this is all iatrogenic. So there's a need to work on disease prevention along with diagnosis and treatment. So let's all hope that with the engagement of many partners, many players, private sector and so on, together we can eliminate hepatitis C from Pakistan, hopefully by 2030. Even if we do it by 2033, that will still be a very great effort, and we hope that many people sitting in this room will be part of that process and will help actively. Thank you very much.